Aloha, welcome to Healthcare in Hawaii. I'm your host, Josh Green. I apologize for my formal attire today. I just came off the Senate floor. We had 300 bills to debate today. I'm happy to have a special guest today, Dr. Thomas Gallagher, who's a physician. I met him just a few weeks ago when we were celebrating the achievements of the social work community. Dr. Thomas Gallagher works very closely with many, many people in our state. He works in a discipline which many of you might not know much about, which is called Developmental-Behavioral Pediatrics. And we're going to unpack that today and find out what it is exactly that practice is comprised of. We're going to hear it from an expert who's been here for many years in the state of Hawaii. I'm proud to say, though, he looks awfully young. He just retired a month ago with commendations from the military. He went to University of Oklahoma. He did his medical degree there, had a pediatric residency as well, became a diplomat of the National Board of Medical Examiners, also for the American Board of Pediatrics, has worked in kind of central part of our country, and then came to us in Hawaii. The reason I met and liked him so much is because he cares for children. And I wanted to read something before we even get started because he's kind of shy. But this is testimony to what Dr. Gallagher's about. Dr. Gallagher has been a faithful provider to the exceptional people that Tripler serves. Special patients require special care and equipment that requires and, unfortunately, involves paperwork and a caring office. His office was in the middle of the group, and he personally provided reams of the paper that was required for our family and many others who had no other source. His kindness and long hours in the job have been a beacon of hope to many and will long be remembered and deeply appreciated. And that was from Paul Good, Sr. And I just thought this was nice to read right off the bat so people get an idea of who you are. So welcome.
Thank you. Appreciate that.
So Dr. Gallagher, you come to us from Tripler.
That's correct.
And I said that you were a developmental behavioral pediatrician.
Correct.
Why don't we start by describing what that means to people? People know what a physician is, but this is a very interesting specialty.
So developmental behavioral pediatrics is a subspecialty area of pediatrics. So you have to go through medical school, finish it, go through a residency in pediatrics, finish that. And then after that, go into a fellowship, except for some of us that are old enough that we ended up doing it kind of without a formal fellowship, but were grandfathered in. And during those 3 years, most of the time in the fellowship, you learn a lot about kids that have got disabilities. They can be physical disabilities, they can be emotional disabilities, they can be a variety of disabilities from a variety of different areas. Sometimes it ends up being in learning, sometimes it's with kids that have been attending special education type of classes or kids that are attending one of the specialty schools on Oahu.
Wow, so you deal with children that have just a very, very wide variety of challenges.
Exactly.
And the thing that impressed me so much about you was not just the energy that you gave off when we first met, but I've been speaking on this program recently quite a lot about developmental concerns. We have been discussing challenges like autism. We've been discussing the environmental cues for autism. We're not going into that today because we've exhausted that subject, but I thought it was terrific luck to meet someone who had the practical experience for the last 3 decades of actually caring for this cohort of children that have significant challenges.
Exactly.
So could you give me an idea and our audience an idea of what does it look like and has it looked like in your practice? What is the spectrum of children that you see day to day, and what were the challenges that you had?
Okay. Well, that whole area of developmental pediatrics, because of what I just said with regards to it being physical disabilities all the way up to emotional disabilities, is really a wide spectrum of kids that we care for.
Right.
I have taken care more of the kids that have got more of the physical disability side because of a variety of reasons. There are 4 of us developmentalists at Tripler.
Okay. 2
of them really prefer doing the behavioral part, and so I've taken on more of the physical disabilities part.
Okay.
So those are going to be children that have got physical disabilities such as cerebral palsy.
Yeah, describe the actual developmental challenges that each of these children have.
So children with cerebral palsy in general, not always, end up being children that have got brain abnormalities either from the birthing process which really is not that many. We used to think it was like 90% of kids with cerebral palsy had cerebral palsy because the obstetricians just did a poor job of delivering them. And what we know is that that's not true. Those kids may have problems at birth, but most of the time they have problems at birth because there's something wrong with their overall physical well-being.
You mean in utero challenges?
In utero challenges, children that have got other issues with blood clots that have passed up to their brains when they were still maybe even during the first few months of life, okay, when organogenesis or the development of organs is occurring.
Yes.
And so we will find that a lot of these children have got abnormalities with brain that shows that they do not have the number of gyri or invaginations or the number of little bumps that is present on the inside of brains.
Yes.
That they should, indicating that something went wrong real early on.
When do you start seeing these children? How old are they usually when you start taking care of them?
Well, most of the disabilities that occur end up occurring, you may see some of them real early on, but the issue that occurs with most kids during the first 2-3 months of life is that really they're functioning at just the brain stem level. And I know that that may sound terrible,
yes,
and it may not sound very complimentary to the way children are reacting.
Yes.
But the brain stem is an extremely important piece of our brain.
Yes.
Meaning that information such as, do I trust you, do I not trust you, am I afraid of you, or if I'm not afraid of you.
I deal with the capital every day.
That's right. All of that stuff needs to be at a level at which the information can be passed back and forth to the upper parts of our brain, our cognitive parts of our brain,
yes,
immediately, instantaneously. Otherwise, we end up getting killed or something else happens. We need to know, yes, I should be afraid of this, or no, I shouldn't.
Yes.
Children, during the first few months of life, really don't, if you look at them, they may smile at you once in a while, but they may be smiling at you because they're passing gas, not necessarily because they really are saying, wow, you're a handsome dude, I really like you, okay? So there's a variety of things that are going on that are really at the brainstem level. That is going to answer your question of when do we start picking up on these kids? Most of the time it's not until they get to be a little bit older that we start noticing.
Yes.
So kids that are only turning to one side would indicate there may be something that's wrong. At 4-6 months, between 4 and 6 months of age, when they're supposed to be rolling over, if they're not rolling over the way that they should, if they're not reaching out to try to grab a hold of things as they should,
yes,
if they're only using one hand instead of both hands when they should be using both, those are early markers of saying something isn't quite right.
Interesting.
So there are developmental milestones that children almost always proceed through.
Yes.
And those developmental milestones end up being very programmably predicted based on something called maturation of the brain or myelination of the brain, which means you're wrapping those neural fibers, those nerves, with a myelin or a wrapping that helps with insulating the nerve. It's kind of like the high lines with electrical high lines, and think of it, if you don't have a wrapping around the wires that are coming from the power station to your house, those are all going to short out, and it's not going to work. So whoever made us, however we got made, whatever happened, did an extremely good job of not myelinating all of those nerves before we're born, so that if there are areas of our brain that get hurt, babies can remap, rewire, reprogram all of those areas. We get rid of a good percentage of all of our brain cells after we're born. And that's the way it's supposed to be. You get apoptosis, that will be getting rid of some of those brain cells, those nerve cells. And the reason that we've got so many extra at birth is because we need to have extra so that if there are areas that are hurt, those can end up taking over.
So what you're saying is there are very clear ways to diagnose a child, especially once they get past the 2 or 3 month mark, where you can start seeing that they are missing their developmental milestones.
Exactly.
And then someone brings them to you
At
and the
least,
team.
you're right. At least in some areas. Now, speech and language, you know that at 4 months, kids should be starting to go,
Yeah.
looking at you, and then at 5 months or 6 months, starting to get a chuckle.
Yeah.
Okay? Those are things that kids should be able to do. Now, if you say, well, how can we tell if the child has got an articulation disorder? Obviously, until they get to be closer to 15, 18 months, when they are starting to articulate words,
Right.
you won't be able to tell that part.
Got it. But you have a very detailed process that you know that the children should be making these milestones. And
Exactly.
I think I should hold these up. This is something that Thomas put together, Dr. Gallagher put together, which shows a series of milestones. And can parents see these, or is this really mostly for clinicians?
I haven't ever thought about that. Maybe what we should do, maybe you can help me figure
Yes.
a way to put that on a website someplace. I certainly don't mind it becoming available to anybody.
Because parents are very savvy. Like at home, my wife she's a lawyer and she likes to study everything, right? And
Exactly.
likes to argue with me. And so she was very in tune, but just through the books that you can get,
Right.
over the counter, or sometimes a pediatrician will give you a
Right.
book about development. But this work that you did really puts into nice charts, and so you can see very clearly at 14 months, at 16 months, at
Right.
2 years, what a child should be doing, and maybe that would be instructive on when is it necessary to bring in the developmental
Exactly.
specialists.
Well, and the reason that I did these with some of my cohorts when I was a medical student and
Yes.
a resident
Mhm.
was because they didn't exist. There weren't good charts of. There were some of the tests, the neonatal and the infant tests, but what I wanted to do was to take from those tests some of the most important milestones that parents will be able to notice, put them into a chart to where parents can look through there and say, my child's only doing 3-month things here and is doing 6-month things here. Is there a problem?
Right.
And the answer is that maybe.
So-
We need to investigate.
So once the child's referred to you, is it from anywhere in the state, or is it just through the military system?
It's through the military system for me because we only take care of the military, Department of Defense, or children that have got access to.
Right, but you have colleagues around the state, I
Exactly.
assume, that have the same
Right.
interests.
There are
and
people
training.
at Kapi'olani, there are people that are associated with 0-3 programs, with Shriners and others.
Got it. And they bring a patient to you, and you begin to see them. How often do you see a child that has developmental delay or significant concerns about their development? Is it every week? Is it every day?
Well, that's daily.
Daily.
Yeah,
Okay.
because that's what we do. I mean, we schedule appointments. We try to get parents to fill out questionnaires to be able to expedite and make things go a little bit faster, so I don't have to ask all of the pregnancy history, birth history, whether there was any alcohol, whether there was any drugs, whether there was anything else that occurred during the pregnancy.
Yes.
Primarily so that we can expedite that eval and I can read through that in advance and have it all down before. But if you don't, they end up being at least an hour appointment, if not 2-hour appointments, trying to get that. And frequently we can't get through all of the information that we need to get through to figure out what's going on.
It's very,
even in
very
2
detailed
hours.
specialty.
Exactly.
Before our first break, why don't you just give me a list of kind of like the most prevalent issues, physical disabilities that you've seen in Hawaii?
So probably cerebral palsy ends up being one of the big ones. We also are associated with the cleft lip and palate clinic, and so
Nice.
that's a fairly large cohort of individuals.
Mm-hmm.
Children that have got spina bifida or meningomyelocele, whatever word you want to use, where there's an opening in their back where nervous tissue comes out through the skin, ends up being a fairly intense kind of an evaluation, because those kids have got all kinds of issues with legs, with regards to bladder, with regards to constipation, and a variety of things that way.
Okay.
So those are more of the physical disability type of issues that come up.
All right. Well, I think this is a good place to take our first break.
Okay.
And we'll come back and we'll talk about what causes some of these concerns and how we begin to treat them.
Superb.
All right. I'm Josh Green, your host at Healthcare in Hawaii. Thanks for joining me.
Here's the deal. I'm Jay Fidel. I'm the host of Hawaii, the State of Clean Energy, which is the Energy Policy Forum's program on Wednesday. That's how we call Wednesday Energy Wednesday. We call it Energy Wednesday every Wednesday. Are you surprised? Okay, and we try to get guys like Jim Alberts here from Hawaiian Electric who can tell us what's really going on in energy. We want to be informed. It's so important. It's the most important initiative in our state. Clean energy is major, okay? And that's why we cover it on this show. That's the deal. What do you think, Sharon?
I think that's great. That's why we're here every Wednesday from 4 to 5, and we hope you all join us so we can hear people like Jim coming on our show and co-host Ray Starling from Hawaii Energy.
Okay, Jim, you've been here today. You've seen this. You heard what she said. What do you think?
I think it's a tremendous opportunity for people to come together and talk about the issues. Oftentimes, there isn't a good forum to bring these key issues out into the public, and this is a tremendous way to go about it. And the activity of this show is essential to keep talking about energy because, as you said, it's such an essential part of our lives that we need to pay attention to it and we need to think about the future.
Okay, Ray, your turn.
Well, this is a special time in the history of Hawaii where we're making some pretty radical changes in the way we use energy and generate energy. And this show is the one place you can count on coming to every Wednesday and hearing something about the latest issues that are on the table, being discussed, that will affect us all going forward. So come join us, and if you have some ideas you want to share with us about energy, give us a call and let us know. We'll put you up here and let you talk for an hour. So come see us.
Thanks, Ray. Thanks, Sharon. Thanks, Jim. It's great to be, from Think Tank's point of view, it's great to have this show. We love the show. It's our most important show. So come around and listen to us 4 to 5 on Wednesday. Thanks a lot. Bye.
Aloha.
Aloha.
Aloha. Welcome back to Healthcare in Hawaii. I'm your host, Josh Green, Senator from the Big Island and ER physician. I'm joined today by Dr. Thomas Gallagher, who is an extraordinary individual. He practices as a pediatrician, but specifically as a developmental behavioral pediatrician. In our first segment, he was able to explain the kind of work and the scope of work he does and has done for many years, for 30 years plus at Tripler, the patients he sees, the challenges that he took up, working with children that had cerebral palsy, very severe illnesses such as spina bifida, which some of you might know another illness as, other developmental challenges that otherwise people might not get care for. He has colleagues in the private sector in addition to match his services that he provided at Tripler around the state. But it's not easy medicine. So Thomas, welcome back.
Thank you so much. Appreciate that.
So when we left off, you were talking about the conditions that you treated predominantly. Why don't we give our audience some better idea of the challenges in your discipline as to what causes some of these illnesses? Are people born with them? Is it a genetic problem? Is it environmental? Why do children have developmental problems?
Well, I guess the answer to that is yes. Okay, so what I mean by that is that as we are going along, the Human Genome Project, which I'm sure you have heard of.
Yes.
The Human Genome Project has allowed us to identify so many minor abnormalities that are present on the chromosomes. And so what used to be only the most severe of children that had disabilities, or children that had very recognizable abnormalities were the only ones that we were really able to pick up on and be able to give a for sure diagnosis or an etiology, a cause for.
These are some of like the trisomies.
Exactly,
and
like trisomy 21, trisomy 18, those kinds of things. So you look at them and you go, this child has got trisomy 21 or Down syndrome. I can tell because I can recognize the child.
Yes.
It looks like every other child. This child looks like every other child that has got trisomy 21 or Down syndrome.
Got it.
And so you're able to identify that. And it wasn't all that long ago, within the last 100 years or so, that we even were able to look at that.
Amazing.
Now what we can do is we can look at very, very minute points on a particular chromosome. that may have an extra piece to it or a deletion to it, and those deletions and additions may be important and they may not be.
So does that mean that when a child comes to the developmental clinic for you, they undergo blood tests and screening?
Frequently do, but not always. So if children come into us and they have, as a developmental pediatrician, as a dysmorphologist, meaning looking for little unusual facial features, little unusual hand features. Is there a single palmar crease? Is the ear a little bit lower than it should be? Are there extra creases in the ear? Is the, you name it, a little bit different than what it is in others? And if they look like they could fall into a syndromic appearance, then yes, we will get chromosomes. Most of the time you start off with regular chromosomes, and then from that, because those are like $300 to $500, as opposed to looking at something called a microarray, which is looking at specific points along the chromosomes, which is over $1,000. And you start talking about real money pretty quickly when you start getting a lot of those kinds of tests. And some of the tests, if you are wanting to completely sequence the whole genome of there, can be up in the $10,000, $20,000 to do. And unless you know exactly what you think is going on, those tests you can easily break the bank with fairly quickly.
But you get a pretty good idea from your physical exam.
Exactly, exactly. And that's kind of what most of us in developmental behavioral pediatrics or genetics have been trained to try to do. So developmental pediatricians are kind of a mini neurologist, a mini geneticist, a mini dysmorphologist, a mini psychiatrist, a mini psychologist. So we try to take pieces of those, all of that spectrum, and learn as much as we can about each of those areas so that we can try to hold together. And that's why so much of the time we are extremely valuable people in the cleft palate clinic. So the ENT, the ear, nose, and throat, the otorhinolaryngologist, or the plastic surgeons or others that are working in the cleft palate clinic will ask us to come in and say, do you recognize anything pattern-wise here that is the reason for this child to have a cleft? Because obviously it makes a huge difference, and it makes a huge difference to the parents, because if there is a syndrome that's associated with this child, you could have a 50-50 chance of having another child with a cleft lip or palate, as opposed to less than 1% or thereabouts otherwise.
So after that developmental workup goes on, and sometimes you do blood tests, sometimes you don't, what's the follow-up like? Like, for instance, you said you sometimes see very young children. Do you see children through the years?
Most certainly. So in a lot of ways, we provide the general pediatric-like care for surveillance for the syndrome or for the type of disability the child has. Now, I will not take care of, in my office, because I would be inundated, taking care of the thousands of kids that I've seen, trying to provide routine medical health care for their runny noses, their colds, their strep throats, vaccinations, and all the rest. But on the other hand, I will see them back, depending on what it's like, someplace between every 3 months, 6 months to a year, or sometimes every couple of years, to be able to look at the surveillance of the particular syndrome, the particular entity, etiology of what it is that they've got. And the reason for that is that obviously if a child has got a syndrome, we know based on other children that have had that syndrome, what some of the usual or frequent types of complications are that will come up. And so I want to watch very closely for, if I know that they're going to have an increased incidence of knee problems, of eye problems, of hearing, I want to follow that closely so that we can get, for ears, if they're going to have hearing loss, I want to know that early so that we can get them aided with a hearing aid so that they can hear. Otherwise, language isn't going to develop if they don't hear anything.
Right. It's funny you mentioned that. So what a lot of people certainly wouldn't have any reason to know. When I was born, I was deaf, and so it wasn't. This was in 1970. I was in a small little town in Pennsylvania. We didn't have access to someone like you.
Right.
And my pediatrician, or our family's pediatrician, had missed it, the diagnosis, and I began to demonstrate developmental delays personally, pretty severe delays, until finally, interestingly, our family practitioner figured out that I had severe hearing loss and
Right.
set me then into the hands of developmental specialists and so on.
Right.
And I had a surgery and my hearing improved and then was able to restore my milestones and so on.
Exactly.
But the interesting part of that story was at the first visit, my mother, who was seeing this pediatrician, who was apparently a very young pediatrician, didn't have a lot of experience, told her, and people who are watching this today might laugh, but they told her, well, Mrs. Green, we're very sorry to tell you, your child, these were the words they used to use, is profoundly retarded, and you'll have to plan for institutionalization for the rest of his life. And he's never going to advance developmentally in any meaningful way. And she was devastated, heartsick,
Right. Right.
Destroyed. My father wasn't there, the grandparents weren't there. Why they came up with that diagnosis so precipitously, goodness knows. And they didn't do a very good job because, fortunately for my mom and my family and me, they were able to work things out. But
Exactly.
it did require some very good diagnostics later, and then
Right.
a whole team of help to get me caught up.
Most certainly.
And that sounds like what you guys do, but now you do it at a very high level.
That's exactly what we do. And children that have got speech and language delays,
Yes.
as you probably know, can be some of the most irritating
Yeah.
kids, because it's like, for me, being dropped off, let's say in Korea, and I don't speak a single word of Korean,
Yes.
and I'm trying to point to things that I want, and people are talking to me 100 words a second.
Yes.
Obviously, it's not that fast, but it seems that fast, and I don't understand a single thing that they are saying, and I can't get my point across, they can't get their point across, and before long, I feel like kicking the dog, kicking the cat, or anybody,
Yeah.
because I'm frustrated. And kids that have got hearing loss have to deal with that day in, day out, and they don't know any different, and it's very frustrating for them.
And you said earlier, it's sometimes difficult to get services and to get, it was described even by that very nice statement that Mr. Good wrote, but how difficult it is to access the services and the extra care that you need. Now, on this show, we've talked many times about the shortage of providers and the shortage of some specialty services. Is that what you see? How difficult is it to get a child who has developmental challenges into speech therapy, into, any number of therapies that they might need? Do you have the resources that you need?
Well, the nice part about Tripler is that it's a government institution, and in a lot of ways, because of the way the laws are written,
Yes.
it is an entitlement,
Mm-hmm.
as opposed to entitlements that exist in the civilian sector, which don't exist. And so,
Yeah.
yes, if we need services for a child, we, by law, have to provide those services. And so we are able to do that. Granted, it's getting significantly more difficult at the present time because money is being diverted to places where we feel that we need it. And then that's not a political statement at all. It's just the way things go.
Right.
But I have been extremely fortunate during my tenure at Tripler, at the military installation, of when I feel like I need to order something and I feel that it's in the child's best interest, that I'm able to do so. Sometimes I have to justify it, but the majority of the times it gets done.
That's extraordinary. Do your colleagues have the same experience, do you think,
In the civilian
the
network?
civilian-
No, not at all. And so, for example, the genetic nurse that we had that came from Kapiolani, Queens, out to Tripler, would say, you'll never get this lab test paid for. Well, yes, I think we will, but in town, we can't get it paid for. Insurance companies won't pay for it. And so the problem that exists with that is that if parents are not able to know, this is due to something on the chromosome,
Right.
that I had absolutely nothing I could have done about this. This is Josh's issue because of his chromosomes, and I didn't do anything to do with it. They feel guilty for the rest of their lives of saying, what did I do? Why did I cause this? What was it that I did? Did I see a snake on the road and it's now the reason that my child can't walk.
Yeah.
Because all of the wives' tales and superstitious types of things that exist are things that the parents end up living with and they feel guilty for the rest of their lives. Once I tell them, it had nothing to do with what you did. You could not have, if you wanted to cause this, you couldn't have caused it. It takes the guilt of that child's issue from the parents. Now, they still feel for the child, obviously,
Right.
but at least they don't have to feel guilty and they don't waste the energy of feeling guilty
Yeah.
for the rest of their lives, and instead can pour that energy into fixing things instead of
worrying. Well, I think before we go into our second break, I think what you do is you offer a lot of comfort and certainty in people's lives. And in my experience as a doc, that's half the battle. It really is. So people can have an expectation about what they can move on to next. And as challenging and heart-wrenching some of the challenges are that our children face,
Exactly.
I've found people to be extraordinarily strong when dealing with really big problems, and they can have wonderful lives with their children.
They're extremely resilient when they know what it is, and they've got some foresight of what's going to be happening, and they're not completely feeling like they're floundering in the wilderness.
That's great. Well, let's take our break, and then we'll come
Sounds
back
great.
for our third segment.
Thanks.
I'm Josh Green, Healthcare in Hawaii, joined today by Dr. Thomas Gallagher.
Just wanted to invite everybody tomorrow, March 10th at 5:30, the official book launch here in Honolulu of The Resilient Investor. It is a benefit for Proto Hub Honolulu at 458 Keawe Street. It's called Resilience is the New Sustainability, and it features me outlining the framework of the Resilient Investor book, along with special panelists, Hunter Hevelin from the Asia Pacific Center for Regenerative Design, as well as Jeff Michelina from WeFficiency, and wanted to invite you to come down and learn about some of the resiliency strategies that are going on here in Honolulu and Oahu to help lead us towards a regenerative future. State Representative Chris Lee will also be sharing some policy initiatives to promote sustainability. So come on down and enjoy the free food and drink, courtesy of Whole Foods and Kona Brewing. Aloha.
Aloha. Welcome back to Healthcare in Hawaii. I'm Josh Green, Chairman of the Health Committee at the Senate, ER physician on the weekend. Today I'm joined by Dr. Thomas Gallagher, who is really a leader in his field in developmental pediatrics. He's here today because after retiring very recently, we have to rely on his expertise. In the first 30 minutes of our program, he's been able to share with us the many challenges, the developmental challenges that our children can face here in Hawaii. Though he's worked at Tripler, there is a companion group of providers and physicians that do the same things that he does in the civilian world here in our state. They have a more difficult time often getting all of the extra specialty services to surround them that he has available at Tripler to take care of children, but he has been able to really clearly tell us what some of these challenges are. So thank you again.
You are most welcome. Thank you.
Now, you spent a lot of time at Tripler building programs as
Exactly.
well, and that was very impressive to me. When I looked at some of the comments that were made about your retirement ceremony, and by no means is this the end of your career, because I know we're going to rely on you going forward. You're young.
Thank you.
But people said that you actually created programs and you made things happen with a lot of resources. Could you tell us a little bit about the programs you brought into this Hawaii system?
Well, when I came to Tripler, I doubled the staff of Tripler in developmental pediatrics. There was one other developmental pediatrician there when I first started. So there were, within 2 weeks, we
Yes.
brought on an occupational therapist, and a lot of that just kind of flourished thereafter to where we ended up with 30, 40 staff.
Wow.
Okay, and part of that ended up being both at Tripler and because of some funding that came into the Department of Defense
Yes.
to provide care and to provide educational, there's really medical assistance in the educational arena through a program called Augmentation of Special Needs Information, Services and Information to Students and Teachers, okay? It
Better tell us what that means.
Goes by the acronym of ASSIST, ASSIST, okay?
Got it.
So Senator Inouye in 1999 and his aide, Dr. Pat De Leon, came to Tripler and said, we need to be able to do a better job of allowing the Department of Education, Department of Health, Tripler to work together.
Okay.
We have got issues between the three institutions of everybody saying it's his fault, it's their fault, they're not doing, etc.
Not taking good enough care of kids with disabilities.
Exactly, or at the time it was taking sometimes 6 months, a year to get kids through the evaluatory process for like the Department of Education.
Mm-hmm.
And when children are here for a rotation with their parents of 3 years,
Right.
and if you spend 6 months to a year trying to get services, and then the last 6 months of your tour of duty is spent getting ready to leave, half of your educational experience in Hawaii may be lost in programs that may not be doing,
So
may
interesting.
not be providing
Yeah,
services.
you don't think about that, but really, most people who have a child with significant challenges, they're in their town. They have their doc. They have the referrals in place. But these families that come, and it's maybe 100,000 people strong
Right,
coming,
right.
But with children and with wives or husbands and spouses, all
Right.
these significant people in their lives, they've got these kids, and their kids are just as likely to have a developmental
Right.
abnormality as anyone else, right?
Exactly.
So they need you to hit the ground running, it sounds like.
We do. The other piece of that, though, is there was a program, it was during the Kennedy years, and you probably know the Kennedys had a daughter with a developmental disability, and so a lot of legislation was put into the public law to be able to provide services in a free and appropriate way to kids that are needing educational assistance.
Got it.
Became FAPE, free and appropriate public education later on, but initially it was public law for the mentally retarded, but we don't obviously use those words any longer.
Right.
What ended up happening out of that, though, was that the Department of Defense was sending kids with disabilities to Europe, and it may be to a real small place, or it may be sending an individual to Alaska, and the educational availability of services didn't exist. So, for example, you take a Navy person and they're assigned to Busan, Korea. And you've got one child that ends up with a speech and language, I'm picking probably a poor one out of this, but speech and language disability.
Right.
And so you end up pulling a speech and language pathologist to Busan, Korea to teach one child. Fiscally, that is irresponsible.
Right.
So we cannot do that. So a program was set up called the Exceptional Family Member Program, or EFMP, to be able to help make sure that we don't send children to locations where services are not going to be available.
Got it.
Now, because there was a couple of children that were lost due to asthma in Alaska because the helicopter let down and the engines froze up and they were unable to get them started to be able to get the kids off back to the mainland to get care.
Yes.
And we lost a kid or two. That ended up saying, the Department of Defense said, well, let's not just do it with educational issues, let's do it with medical conditions, medical conditions as well. So EFMP is for making sure that we don't send kids with either educational or medical problems to locations where the services don't exist to be able to take care of them well.
Right. And how did that tie into what you were doing here? You were expanding a program. You were building a program.
We did, and so there are other peoples that came, there are other individuals, there are other providers that came on under EFMP. But then with Senator Inouye and Pat De Leon, Jennifer Goto-Sabas's assistance, we were able to bring money to do a demonstration project to Hawaii to be able to say, can we do a better job? Can I, as a developmental pediatrician, can another person as a psychologist do a better job of evaluating a child for an educational a medical diagnosis, a medical condition with an educational implication. Can we do a better job of doing that in the classroom where we can see what the child is doing, what kinds of issues the child's having? Why not make it to where we can see what the kid's having issues with?
Yes.
And it's a whole lot easier. That no questionnaire is ever from a teacher or from a parent is ever going to be able to show you the flavor of what the issues are in the classroom the way 10 seconds of watching a child in the classroom will do.
You're speaking of, say, something like dyslexia.
Dyslexia, central auditory processing difficulties, in which children are unable to process information as quickly as it's coming in. So they are still trying to figure out with, Josh, you look nice today. They're still trying to figure out with, Josh, you. Why is she saying you, not me? Did she say you or did she say Hugh? I don't know exactly what she said. And so everything coming out in mumble, they can't figure out what the words are. So they're still trying to figure out the words when the teacher's already at something else. And so they're frustrated and they're giving up. And if you're looking at what's happening with the teacher and the child going, I have no earthly idea you're speaking Greek. I have no earthly idea what you're saying. You can see that frequently in their eyes up front, and it gives you a cue as to what's really going on.
And this program was able to be rolled out in Hawaii over the last, I guess that's about 15 years now.
Well, it was from 2000 was the beginning of the monies and went till 2010. So we had 11 years of funding that was congressional special interest funding that accounted to about $20 million that came in that the state and we, through the Department of Education, were able to benefit not only the military kids, but by spread of effect, all of the kids in the educational system.
Sure. It's just, it always blows my mind, but when we mentioned this earlier, when we were talking before our program, of the really incredible and broad impact that Senator Inouye and his team,
amazing.
Jennifer and Pat, had over all those years. So we send our thanks again to
Amen.
Our late senator.
Most
and
certainly.
It was wonderful. Well, we're coming down the home stretch here, Dr. Gallagher. I thought maybe we'd spend just the last couple minutes, 2 or 3 minutes, allowing you to wax philosophic about what you think should be done in your field for Hawaii. What would be your dream if you were able to do anything for the people of Hawaii and the children with developmental disabilities? What would it be?
I think it's extremely important that we don't lose sight of what it is that we're trying to do. And that is obviously trying to take care of the kids that have got the disabilities. Number one. Number two, a lot of times the children that have got more severe disabilities end up out of public law being taken care of, and they end up getting the services that they need. But there is a huge gap group of kids, that I like to refer to as the last to get picked and the first to get picked on. Kids that have got educational issues and they don't meet the eligibility criteria that is set up by public law or Hawaii law, so they don't have the 1.5 standard deviations below their potential. Those kids, though, have got the greatest potential by far, to make the greatest impact for all of the state of Hawaii. And they, like you, are kids that can do something and can make a huge difference. And I appreciate the fact that you are able to do that and you have done that.
Thank you.
No,
And
thank you.
I didn't expect to even remember that, as we met and got to talk. But
Exactly.
It just goes to show you that when you give people an opportunity to just have a chance to, in some cases it's a very basic diagnosis, in some cases it's having a team around for the first couple of years.
Exactly.
That a world of difference can be made.
Amen.
And
Most certainly.
and we should never lose sight.
No, that's a wasted opportunity / life that we just can't afford to do.
Okay. Well, thank you so
No,
much,
thank you.
Thomas, for
Thanks so
being
much.
with me today.
Well, certainly.
So this has been Josh Green, Healthcare in Hawaii, your program on all things health in our state. Today I was joined by Dr. Thomas Gallagher, a developmental pediatrician with a reputation that is so extraordinary I thought we had to have him on our program. We'll continue to have these dialogues in the coming months about all the challenges in healthcare and related fields in our state. Thanks for joining us.